Good morning, this is Elizabeth Butler, and this is my Doctor of Nursing Practice Project PowerPoint presentation for burnout among nurses who worked on a COVID unit. I'd like to introduce you to my committee members, my chairperson, Dr. Teresa Gallicados, my second reader, Dr. Snell, and my community member, Dr. Yang. And I'd like to thank them for their support during this, the past 2 years. This next slide shows my educational background. I earned my bachelor's degree in nursing from Washington State University in 2007, my master's of science in nursing with a family nurse practitioner concentration from the University of Nevada, Las Vegas in 2014, and plan to graduate with my doctor of nursing practice from Maryville University later this month. This whole DNP project all stemmed around the theme of burnout. Burnout is described as exhaustion, depersonalization, and reduced personal accomplishment. In a recent study, 54% of first-year nurses suffer from at least moderate burnout, with an increase in burnout symptoms of 10% after 1 year. The impact of nurse burnout resulted in a 12% nurse staff turnover rate, which is significant for an organization. When nurses feel burned out, they feel they aren't performing their job duties at the expected level. That results in a lack of motivation and poor personal job-related self-esteem. The Tri-Council, funded by the American Nurses Foundation, held a virtual summit in December of 2020 to discuss nursing successes and failures during the COVID pandemic, implications for nursing education and regulation, and created a framework for post-COVID healthcare advocacy and change. The recommendations made during the summit requires an organizational response to help nurses with self-care. A rapid response is needed now to support nurses before they burn out, quit, or leave the profession altogether. It is vital for organizations to provide nurses with the necessary support and interventions to reduce the physical, mental, and psychological impacts caring for patients with COVID has had on them. In March of 2022, President Biden signed into the law the Dr. Lorna Breen Healthcare Provider Protection Act that is designed to ensure healthcare professionals are provided with mental health support to address burnout. Dr. Breen was an emergency room physician in New York who worked closely with COVID patients. She acquired COVID, recovered, returned to work, then tragically died by suicide. Prior to the pandemic, she did not have any known diagnoses of mental health issues. This is one instance that outlines the mental health impacts caring for COVID patients has had on caretakers. Nurses faced insurmountable challenges during the COVID pandemic, knowing that they had to reuse N95 masks, wear garbage bags to work as there was a shortage of gowns, and care for patients who needed ventilators, knowing that ventilators were being rationed, care for patients they knew would eventually die alone without their loved ones. But nurses continued to show up anyway. The impacts of COVID-19 on nurses were beyond physical and mental. Caring for COVID patients also carries psychological impacts. The fear of infecting family members or other patients was the main concern that nurses expressed. The main psychological impacts on nurses caring for COVID patients included fear, frustration, anxiety, depression, and social isolation. Other nurses reported feeling anger, compulsivity, obsessive thoughts, apprehension, and betrayal. When comparing the mental health of nurses pre-pandemic to during the pandemic, there was a higher incidence of mental health symptoms among nurses during the pandemic. This leads us to the DNP question. Will a 10-minute per day mindfulness intervention over a 30-day period reduce the feelings of nurse burnout among those who worked at least 100 hours on a COVID unit at a long-term acute care hospital? The purpose of this project was for quality improvement and practice improvement. This project was aimed to identify nurse burnout in a population and address it with a daily mindfulness intervention. Burnout among nurses has a direct correlation with lower quality and safety ratings. Thus, in theory, reducing burnout will elevate quality and practice improvement. The population studied were nurses who worked on a COVID unit for at least 100 hours at a long-term acute care hospital in the Western United States. This next slide is a review of the literature. Many articles were analyzed prior to the start of this project. The main theme of the articles from the literature review was that nurses reported feeling overwhelming exhaustion and a sense of ineffectiveness while caring for COVID patients, lack of personal protective equipment, high patient workloads, and the uncertainty of the virus left nurses feeling worn out and depersonalized. Those with decreased support systems, including lack of social and emotional support, were more likely to burn out. The review of literature also mentioned strategies to address burnout, which included self-care measures, resilience training and stress training classes, and organizational support. All articles examined for this literature review examined the prevalence of COVID-related nurse burnout, detected risk factors leading to nurse burnout, and described the associated mental health and organizational consequences of untreated burnout. During the pandemic, frontline workers, especially nurses, provided care to high volumes of acutely ill patients. Recent studies have shown that pre-COVID, 20 to 30% of frontline healthcare workers had considered leaving their professions. In the spring of 2021, during an active phase of the COVID pandemic, 43% of bedside nurses were thinking about leaving their current positions. An additional 5% of intensive care unit nurses, so a total of 48%, also reported a desire to leave nursing. So pre-pandemic, it was 20 to 30%, and during the pandemic, it was 43 to 48%. The information learned from this robust literature review provided a foundation for this project. The theoretical framework chosen for this project was Orum's self-care nursing deficit theory. Orum's self-care theory evaluates one's ability to maintain physical health, such as activities of daily living and hazard prevention. According to this theory, self-care deficits occur when one's self-care agency is not adequate to meet one's physical needs. This theory applies to the phenomenon of nurse burnout. When nurses are unable to provide self-care agency to meet mental health needs, there's a self-care deficit on a psychological level that can result in burnout, depression, anxiety, stress, exhaustion, and depersonalization. Orum's self-care deficit theory has been implemented in nursing research. Tanaka 2022 applied the theory while researching nursing students who were experiencing burnout syndrome. Findings reflected that many of the nursing students felt trapped, defeated, and detached due to burnout symptoms in the form of mental and physical exhaustion, as they reported having little time to satisfy their personal needs. In this specific research project, Orum's self-care theory effectively identified burnout and depression among nursing students with proposed interventions to encourage self-care activities to address it. In this case, the Orum self-care deficit nursing theory is used to evaluate the coping needs of nurses who care for COVID patients. Orum's theory supports strategies that increase resiliency and reduce burnout. This was a quasi-experimental pre-test post-test design using the Maslach Burnout Inventory Scale. The MBI, or Maslach Burnout Inventory Scale, pre-tests were completed by participants within 5 days of starting the 30-day intervention phase. During the 30-day intervention period, the nurses engaged in a mindfulness intervention for at least 10 minutes per day. MBI post-tests were completed by participants within 5 days post-intervention phase. The NBI scale, Maslach Burnout Inventory, measures 3 phenomena, including exhaustion, depersonalization, and personal accomplishment. This is considered to be the gold standard scale used in research to measure occupational burnout due to its reliability and accuracy. The higher the exhaustion and depersonalization scores, the higher level of exhaustion and depersonalization the nurses experienced, hence the higher level of burnout. Whereas the higher level of personal accomplishment and success, hence the lower level of burnout the nurse experienced in that category. Since two of the categories reflected higher burnout with higher scores, and the third category measures higher burnout with lower scores from the MBI questionnaire, the total score is not used to provide any meaningful data. For this reason, all three categories are analyzed separately. The sample information, so all participants were registered nurses at a long-term acute care hospital in the Western United States. They all had active registered nurse licenses. They were all employed at the long-term acute care hospital for at least 6 months prior to the start of the project, and all had worked at least 100 hours on the COVID unit at this long-term acute care hospital. So the nurses must have met the following inclusion criteria just listed and agreed to the terms of the project and sign the consent form. Initially, there was 49 nurse participants who had started. 5 dropped out for various reasons, leaving 44 participants who completed the intervention phase. And the statistician at Maryville University advised at least 41 participants were needed to provide statistical significance. So we ended up with 44, which was above 41. So we had the number that we needed for this project. The gender, 32 were female, 12 were male, and 19 were Caucasian, 15 Filipino, 4 African American, 3 Hispanic, 2 Indian American, and 1 of another ethnic group, and all self-reported living within 30 miles of the long-term acute care hospital, which was located in the Western United States. Both the Kolmogorov and Shapiro-Wilk tests were used to assess normality. A paired t-test was used to analyze the 3 sets of data. To run a paired t-test, certain assumptions must be met. One of the assumptions is the variables must be normally distributed for both pre- and post-test measures, and the data in this case was. The mean pre-test and post-test scores of all 3 categories reflected small yet statistically significant reduction in burnout. Both data for exhaustion and depersonalization scores reflected small yet statistically significant reduction in exhaustion and depersonalization post-intervention. Exhaustion had the most statistical significance in the scores, followed by personal accomplishment, then depersonalization. And as you can see here, the mean pre-test for exhaustion score was 36.45 with post-test 34.30. So this shows a 2.15 point drop in exhaustion, 2.15 reduction of exhaustion, which was the most significant. The pre-test depersonalization mean was 34.95 with post-test mean of 33.86. So this shows a 1.09 point drop in depersonalization. And the increased personal accomplishment score shows an increase in personal accomplishment. And you can see there that there was a statistically significant increase in personal accomplishment, which is great. This shows the results. The paired one-tailed t-test results are reflected. After statistical analysis using paired t-tests were run, there was statistically significant improvement between pre-test and post-test scores of all 3 categories after a mindfulness intervention was implemented. So you can see here exhaustion had a power score of 0.99, which is very strong. An adequate study power should be 0.8, which is 80%. The higher the power score, the less chance of making a type 2 error. So the 0.99 is very strong. The personal accomplishment power score was 0.979, which is also very strong, as it is significantly higher than 0.8. The depersonalization score of 0.726 is not quite 0.8, so the chance of making a type 2 error is more likely in depersonalization than personal accomplishment or exhaustion, but it is still a reasonably strong power score. This project had limitations. The data collected reflected strength and clinical significance. However, the effects of the intervention did not show enough strength to reflect real changes in burnout, meaning many of the nurses' scores post-intervention showed nurses weren't as highly burned out, but still landed them in the high burnout range. Some of the nurses pre-test showed them at the high range of high burnout. In post-intervention, the burnout reduction landed them in the middle range of high burnout. A future study lasting 6 months or more may be indicated to show significant improvements. This was only 30 days. There really wasn't a lot of time to show much improvement, but even with the short 30-day period, we still did see improvement. Collaboration with the LTAC administration to take a dynamic approach in reducing burnout may be helpful. Organizational interventions combined with self-care interventions may show a greater improvement in burnout. Not only will organizational efforts potentially help improve burnout, but it will provide additional support for nurses in the workplace. Organizational support has been shown to increase job performance, nurse retention, and loyalty to the institution. This is the discussion slide. Previous studies have shown that effectively reducing nurse burnout involves a multifaceted approach involving both the nurse and the organization. This means that effectively reducing burnout is up to both the nurse and the organizations to provide interventions. Nurses have a responsibility to engage in self-care measures, as organizations have a duty to provide a supportive work environment with reasonable work hours, workloads, and expectations to prevent nurses from feeling overworked and burned out. Organizations are also encouraged to provide nurses with stress reduction and mental health resources for all nurses who are interested. There was a suspicion the burnout scores would come back high, but almost all 44 participants scored in the high-level burnout ranges for all 3 categories. Even with the reduction of burnout scores post-intervention, 41 participants still reflected high-level burnout scores on the MBI post-test. Although the MBI post-test scores showed statistically significant improvements in burnout, the improved burnout scores still landed most of the nurses in the high-level burnout categories. The implications for nursing practice. The findings from this DNP project reflect a dire need to evaluate and treat nurse burnout. The physical and mental health of nurses is being compromised by the demands of their workplaces. Nurse burnout has a remarkable impact on quality and safety. The high levels of nurse burnout, as reflected in this study and others, should be alarming to the healthcare community at large. The implications of nurse burnout threaten the stability of the nursing workforce. The study indicates the need for a rapid response to save nurses from leaving the bedside or leaving the profession altogether. This data also suggests the importance of teaching nurses self-care interventions to prevent and deal with burnout. Additionally, findings illustrate the importance and responsibility of hospitals and facilities to take care of nurses. In conclusion, nurse burnout is a complex phenomenon that is not easy to solve. There are many layers to this issue, and there's no easy solution. Additional research is needed to study other self-care measures nurses may engage in to reduce burnout. Research is also needed to examine the effectiveness of organizational approaches to reduce burnout. Based on the findings of this study and extensive analysis of similar studies, reducing burnout is dynamic and involves the participation of nurse advocacy groups and associations, policymakers, organizations, and nurses. Thank you for allowing me to present my DNP project to you today. If you have any questions about the information that was presented, please feel free to send me an email, and my email address is listed right here on this slide. The next page is my references. Have a great day.